Prescribe Orly, your number one podcast in Northern Ireland
for medicine and all types of learning biology.
Yeah. So today, well, it's your host Shatner,
Chris,
and today we're going to be talking about eczema.
Eczema, yes.
Eczema. I don't know if I'm pronouncing it right, but
well, sure. Eczema.
eczema.
You can say any way you want, really.
Yeah,
But
that's
so this is the podcast where we discuss and learn through a topic, and you guys are here to join us. We are not trying to teach this topic. We are trying to learn it ourselves, and you guys are just able to, join us for the ride and
so
revise with us.
Kick back and relax and
Grab
have your
yourself
coffee ready
and tea or other beverage.
and learn with us.
Okay.
Let's go. Clinical features of eczema.
Aye. Well, it's pretty common disease. So
Yeah, but is it self-explanatory for someone?
Probably not. So when we think of eczema, we just think of the sort of very common itchy, red, flaky skin that you get, and people tend to think that this occurs in kids.
Okay.
Now, normally when we learn about it, it's always on the sort of flexor sides.
Right.
However, it actually differs according to the age of the patient. So in infants, you'll typically see it on the face and trunk. With younger children, the extensor surfaces, and then with your older children, you get the typical sort of flexor surfaces getting involved, and the creases of the face and neck.
Creases of the face and neck.
Yes.
Okay. Righty-o. So you can differentiate between acute and chronic eczema, or eczema.
Yes.
So like on an acute, it's high level of inflammation with the red edematous skin and papules or vesicles.
So it's like your wet eczema.
Your wet eczema.
Yeah,
We'll come back to that anyway.
Yeah.
And your chronic eczema is like more dry, red, slightly thickened. So if you think about it, it's kind of like you're narrowing it down to like acute and chronic. Acute means just a flare up that's a start.
Yeah.
Chronic, it's been going on for a while, so of course it's going to be dry. It's going to be more dry, and
you're going to start getting your sort of skin thickening or lichenification.
Yes.
Maybe we could try and get we should probably have a trigger warning. Some of these images that we put up may be a wee bit sort of uncomfortable for some, but this is for educational purposes.
And that's if you're watching it on YouTube.
Yes.
Please do watch the video on YouTube. It's crazy.
Subscribe, comment.
Yeah.
So
we'll get Alton, our editor, will put up the image here for
lichenification.
Alton.
He's learning with you.
So so pathophysiology of eczema. It's something you should always like try to know.
Yeah.
Like it gives you a good grasp of what it actually is.
It's always good to take it back to first principles, and then when you're in your sort of OSCE or your clinical stations, they can maybe ask you to do some counselling stations, which is involving explaining to patients what eczema is. So to be able to explain it nicely to them, you need to understand the underlying pathophysiology for it. So to start off, there is a certain genetic disposition to it, and
that's mainly for atopic eczema.
Most common type.
Most common type of eczema. So pretty much it's kind of like, what way do they put it in OSCEs? It's like brick and mortars, or is that?
Yeah. Brick and mortar sort of idea of
so often if you put a brick here and then like
in the middle.
we put a mortar in the middle. So like the primary defect is in the skin barrier function. So like
you get your increased water loss from the skin, and it's opening up holes to irritants. So imagine when you look at a brick wall, and the motor starts to come out from the brick wall. There's like wee
cracks. There's gaps for things to escape and as well as go in.
So that could be any of your irritants or allergens like dust or pet sort of hairs and things like that, and irritants like certain chemicals and soaps and wool jumpers. So if you're explaining it to a patient, try and use it as a brick and mortar.
All right, Bob the Builder. And it causes obviously inflammation. It's one of the biggest things. eczema.
Yeah, because you get your increased sensitivity to irritants, like the ones we previously mentioned.
Yeah.
So then you get your inflammation and pruritus from that.
From that, and another thing to remember about eczema is the itch-scratch cycle, because it's constantly like whenever it's itching, you just scratch it.
Yeah, exacerbating
it
the whole
exacerbates
problem.
eczema.
Yeah. So that itch-scratch cycle, the itching causes more breakups in that brick and mortar.
Yeah,
and which then leads to more irritants, more water loss, more dryness.
Yeah.
So
that's
pathophysiology.
Pretty much covered.
All right.
So we're going to talk about clinical subtypes of eczema. So it can be split into intrinsic and extrinsic. So your intrinsic being atopic, seborrheic, discoid, pompholyx,
pompholyx,
and your varicose or venous eczema, which is your intrinsic, and your extrinsic is contact dermatitis and contact allergic dermatitis. So pretty much eczema is like dermatitis.
Yeah.
Eczema equals dermatitis.
Yeah, they're used, back and forth.
Back and forth. Just a wee term. And
commonest form of eczema, as
like we mentioned,
is
atopic
eczema.
eczema.
And that's, I think, in 15 to 20% of children will have the atopic eczema version.
Yeah, and often they do have genetic predisposition, like you mentioned. And
typically you'll get other sort of symptoms with that. Or other sort of things come with that. So you actually have an increased chance of hay fever when it comes to eczema as well. And asthma is also added on, because I guess it's that same inflammatory response. It's an IgE mediated immune reaction. So that's going to increase your chances of the hay fever and asthma as well. So
just another thing to mention is like whenever you go into like an exam setting, just to remember eczema is your flexural, psoriasis is your extensor.
Yeah. So typically. Yeah.
And flexural is around here, just flexing my biceps,
Oh yeah.
Whoa. Flexing your biceps for eczema.
You hitting the gym, bro?
Yeah.
It's nice.
If you think about it, eggs, flex, protein, eggs.
Eggs and flex.
Eggs and flexing, yeah.
It's a bit of a stretch.
But it's worth it. And psoriasis is extensors, so these bits.
Aye.
Cool. Differential wise, there is differentials. What are we talking about differentials for?
Yeah, so your differential diagnoses of your eczema.
It could be anything.
It differs depending on the age of the patient you had again. So, in infancy, you can get your seborrheic eczema. Which I believe.
We'll come back to that.
Well, yeah,
but
we'll come back to that.
And in childhood, it's scabies. In adults as well.
You can also get scabies. It's a bit more. When it gets to adults, you can get massive sort of variation. You can include scabies, seborrheic dermatitis, contact dermatitis, any drug reactions as well, and mycosis fungoides as well as another.
Just sounds funny.
Do you laugh at the fungoides bit?
Yeah.
Well,
fungoides. Fungoides. That's pretty cool.
That's a more skin infection that you're coming across, and in particular, this is quite a good point in when you're doing questions, is when they describe that the eczema is localized to the hands, you should always think of like a contact dermatitis.
Yes.
Which is quite common in those, cooks, nurses, doctors, those who wash their hands a lot could actually have a sort of adverse reaction to the soaps that are being used in their work.
That's actually caught me out in quite a lot of questions before, so it's something definitely to look out for. And so main infections that you need to think about whenever it comes to eczema, main complications is your secondary Staph aureus, and patients will present with crusty use and rash associated with erythema, and that's pretty much
It is often mild, and you would just treat with antibiotics as it is a bacterial infection. But yeah, normally to avoid this, you would use your management options for the eczema, which we will get to.
So that's just your emollients and topical corticosteroids. We'll get to more details at the end.
Of that.
And eczema herpeticum, it's pretty much your herpes simplex virus.
Doesn't look particularly nice when you see it on patients. It's not a pleasant
Do you know what?
infection to have.
I've actually seen a patient with this in the hospital, and it really wasn't pleasant.
No.
You know,
a lot of tiny little we sort of pustules, is it, or is it?
It kind of looked like
wee vesicles, punch out erosions, vesicles, things like that. Kind
of looked like dragon scales, So yeah.
And typically is in big patches across the face.
Yeah. So it's not. So it's like punched out erosions and vesicles, like you mentioned, and they require specialist treatment. So something to think about. Athen, if you can find an image for eczema herpeticum on Google, put it up
perfect.
Here. That'd be great. So yeah, two main infections: eczema herpeticum and secondary Staph aureus. Just remember that. Okay, so moving on to the management.
Well, we can have our sort of list of medications used because there's going to be different management.
Yeah.
If it's going to be mild disease, moderate disease, or severe disease.
And how do you know which one's mild? How do you know which one's moderate?
So from memory, it's the sort of clinical picture.
Yeah.
So if you have
I kind of threw you in there, didn't I?
Yeah, you did. You're really testing my knowledge here, man.
Yeah.
Is it just the degree of inflammation, and if there's many pustules and vesicles present?
That's pretty much the gist of it anyway. So for like a sort of mild eczema, you would use hydrocortisone 0.5. Yeah.
Okay.
And then it just keeps on going up. So like, so
that's the weakest steroid you can use for the mild sort of condition.
Yeah. And then it gets onto betanoate, which is your moderate, and humulate. These are some things you just need to remember.
Well, that's like moderate is a betamethasone type of steroid.
Yeah.
And then from there,
just remember hydrocortisone is for your mild. That's the biggest things, and then
you also have to use your emollients at that point and soap alternatives. Just to you're always wanting to maintain the skin and then manage any flare-ups. So the maintenance of the skin is using your emollients and soap alternatives.
Yeah.
Which is always going to start off with mild. You're going to start off with the emollients, soap alternatives, and then work your way up to your sort of topical steroids to deal with those flare-ups that occur.
Okay.
And then once you get to your moderate sort of levels of eczema, you continue your emollients. You go up to your moderate topical steroids, like you said.
Yeah.
The betamethasone ones. Then you can also use topical calcineurin inhibitors.
Oh yes, this is the one that inhibits the chemical that activates T lymphocytes. So like less inflammation, realistically, is that the principle behind it?
Decreases immune response. Okay.
Yeah.
And
so those are your like tacrolimus.
Yeah, tacrolimus and your pimecrolimus.
The limus.
I hate these jokes. I can't pronounce any of these things.
I just think about like
tacrolimus. I can say
calcineurin, like vitamin C, lime, like a lime. I don't know. It just works for me.
Oh my word. Okay.
Yeah, so that's also used in moderate.
Yeah, and then also you can use bandages as well to sort of cover the skin. And then finally with your severe, you continue with your previous set of emollients, your potent topical corticosteroids, which is your heavier duty one, which I can't remember off the top of my head.
Yeah.
Your
which one's that?
Higher than the betamethasone one.
Is that the dermaweight maybe?
It could be that one. Actually.
The very potent one is, so it goes hydrocortisone, umaweight, betanoate, and dermaweight.
Okay. And so they're the brand names.
It's like Hebd.
Heb.
They are brand names, but I'm not going to remember the clobestone butyrate or betamethasone valerate or clobesterol propionate.
Good job.
Propionate.
Very, very good job, yeah.
Thank you, bro. Actually, wow.
You didn't mess that up, to be fair.
4/4 of the way to doctor, and I can't mess up a medical name at all.
And then with severe, you also can start going into your phototherapy and your systemic therapy. Systemic therapy meaning more ingestible, like oral steroids instead. And phototherapy is, light therapy.
Yeah,
it's in the name. And then also you need to ensure that you provide some non-pharmacological support.
That's your dermatology nurse. Yes, and then you get like a psychologist to break the itch
scratch
cycle. Yeah, that usually helps, because that's, like I mentioned, like that's one of the biggest things in eczema, the itch scratch cycle, from what I remember from my research. Yes, I do research into these things.
Oh yeah, is that right?
Yes.
Okay.
And so we've talked about that was all for atopic eczema. Now we're going to talk about, we're going to rush through. We're going to like fire through other intrinsic ones.
So you remember all the intrinsic types,
which is your seborrheic, discoid, pompholyx, varicose, and osteotic.
Yeah.
So seborrheic, right? Something you need to remember, affects the scalp, the T-zone, and facial T-zone.
Yeah.
Facial T-zone's this, isn't it?
Yeah. Forehead, nose.
Draw me a T up here. Yeah. Cool. And your upper trunk. So if you have someone big chest like me.
Oh yeah.
Yeah. Upper one.
Yeah. Benching all the time, bro.
Benching all the time. So seborrheic,
eczema, and you would treat with emollients and occasionally
antifungals
or mild topical steroids.
It's associated with overgrowth of yeast.
Malassezia
furfur. Yeah. Remember that seborrheic eczema, Malassezia furfur, chest hair furfur.
Oh, that's actually a good one. I like that. Yeah. Then with your discoid eczema,
just as it explains discoid.
Yeah, round patches. They'll have very intense itch, and your treatment is going to be potent topical steroids because it's quite difficult to treat. And then pompholyx eczema is blistering acute eczema, and I think that typically occurs on your palms and the soles of your feet, and it's tiny little sort of blistering sort of red papules that occur on the hands and feet, and
it's linked to hyperhidrosis, which is
excess sweating, isn't it?
Excess sweat,
off the top of the head.
Nice. And you got your varicose eczema. So
that's your secondary to chronic venous insufficiency.
So pretty much like someone with pure perfusion.
Pure venous perfusion causes the skin to sort of break down a wee bit.
And there's like a hemosiderin deposition, which is like the color change around that area.
That's just sort of, if you'll see this in typically the more elderly population. You'll see these kind of big brown patches on their shins, and that's your hemosiderin deposits due to the venous insufficiency breakdown.
They use compression stockings and emollients for this.
And then finally your aesthetotic eczema, and it's just a descriptive term for very dry skin.
I
pronounced that right, okay?
Yeah,
I did. That was good. That was good pronunciation.
That was very good.
And you're just treating with
it's pretty much aggravated by soap and low humidity. So treatment is usually
just emollients.
You're
in this situation. I keep thinking back to your sort of first principles of, well, if it's dry skin, how do you help with the dry skin? You put an emollient on top. The dry skin is the lack of motor in between the bricks. Yeah. So you need to fill the gaps.
Boom. You heard it here first.
Boom.
So
extrinsic forms now.
That was all the intrinsic. Now it's extrinsic, and that's your contact allergic dermatitis and contact irritant dermatitis. And like Chris mentioned before, contact allergic dermatitis is a delayed hypersensitivity reaction to substances, which is IgE mediated. Am I right?
Yes, I think so. Off the top of my
Learning
my
something
head.
new every day.
Aye.
And the commonest allergens are like your nickel, fragrance, like hair dye. So pretty much the distribution of the eczema.
Yeah, like it will follow. So like we both have.
Yeah, it
necklaces on
changes.
currently,
So like if it's around like where your chain would be, like if it's around where your ring would be.
I typically get it around my
wrist.
My wrist. Where
Oh,
my watch sits.
Look at that!
There we go.
Look at that! Zoom in.
See, man.
So
trying to flex the ice on the wrist.
yeah, flexors,
eggs,
eczema,
eczema.
flexors. So yeah.
Oh my god.
So it's diagnosed with patch testing.
So you need to see what you're allergic to.
So like that's usually what
and
we
then,
get.
with your contact irritant dermatitis, this is the more hand dermatitis that I was talking about.
Yeah.
Where if you're frequently washing your hands, if you're in the sort of healthcare atmosphere, or if you're working in hairdressers, washing your hands, or if you're a cleaner, you'll get this distribution over your hands. And actually, it looks pretty difficult to deal with. Like some of these images are pretty horrific. It's a lot of damage to the skin. So you would always counsel them on wearing gloves, and they may actually have to consider changing occupation if it gets really bad. So this is kind of caused by the constant rubbing your hands is rubbing away that motor again. So therefore treatment is going to be your emollients. And
I've actually seen that in hospitals. There's usually like hand creams now as well.
Oh yeah, to prevent that.
Yeah.
Go on the NHS, keeping us safe from contact irritant dermatitis.
Yes, it's great. Also, advice on topical steroids. That's what we didn't cover. Using the topical steroids, like one fingertip is equivalent to about 500 mg. So it's sufficient to treat a skin.
Like twice the size of your hand with your fingers together. So it can cover about this much.
So this much can cover about that. Could we lift it up? This much can cover about that much. That is crazy. And do you need to apply the topical cortex? You don't use it more than twice a day. And use the emollient first.
Yes, I forgot about that part.
That was one of the things I usually forget. It comes up in exams. Use the emollients first before,
and then you have to wait a few minutes as well.
For it to dry.
For
dry,
the
like settle in.
To settle in.
But that's us pretty much for today. If you like
our podcast, or YouTube video / YouTube video, like, comment, subscribe,
and also if you want to learn anything, we'll put in your request. We might
answer you guys. If we want to. Please comment. we need the information.
We need all the interaction.
Yeah, for sure.
Peace out. Bye.
See you. Bye.